Hello and welcome to the ACOEM Occupational Lead Poisoning New Guidelines for Clinical Management webinar. Today's program will briefly review the toxicity of lead and the evidence for the new guidelines. The speakers will discuss the application of the new guidelines and will give several case studies involving challenging clinical situations with lead exposure. You will also learn how the new guidelines may be applied even under existing OSHA standards. This program is being recorded. There is 1.5 CME and MOC credits for this program. You received a verification form with today's instructions, or you can follow the link that was in the instructions. No certificates will be sent to you, but your transcript of this and other ACOEM educational programs can be viewed and printed from the ACOEM website. Members and non-members can both view their transcripts directly from the website. Today's program will consist of approximately 75 minutes of lecture with questions at the end. We will address questions as time permits and suggest that you submit your questions early for consideration. We are only accepting questions electronically. On the screen, you can see how to open the box in order to submit your questions. This was also in the PDF file of your handouts you received with the instructions. On behalf of the presenters and planning members, we would like to announce that there are no disclosures to be made. So, at this time, it is my pleasure to turn the program over to Dr. James Seward. Dr. Seward, you may begin.
Well, good morning, everybody, and thank you very much for joining us. I'm Jim Seward, and I'm at the University of California, San Francisco, and Lawrence Livermore National Laboratory. And we're joined this morning by Michael Kosnett, who is at the University of Colorado, Denver Health Sciences Center, and Drs. Robert Harrison and Ray Meister, and both of them share their time between the California Department of Public Health and the University of California, San Francisco. I'm just going to take a few minutes to give folks some background on the development of the guidelines for clinical management of lead toxicity that we're going to be discussing this morning. Because I think it's important for people to understand the disconnect that we currently have between the OSHA lead standard on this slide and the guidelines that are being proposed. The OSHA lead standard was issued over 30 years ago, and there has been a tremendous amount of scientific research that has gone on in the interim, demonstrating that there are health effects from lead at lower levels than was previously understood when the guidelines were initially written, when the standard was initially written. In the interim, both CDC and EPA have lowered acceptable lead levels for children. So, our feeling is that the OSHA standard is probably no longer sufficient to protect workers. In fact, people were recognizing this over a decade ago, and at the 2000 Adult Lead Epidemiology and Surveillance Program meeting, there were a number of problems with the existing standard that were identified. First, many laboratories were giving back misleading interpretive information on blood lead level reports. And as I mentioned before, the standards were based on old information with newer research. And there really were no adult guidelines that were equivalent to CDC's guidelines for children. Out of the ABLES meeting, a panel was formed to begin thinking about how to best update the guidelines and to begin to look for funding sources to sponsor such an effort. In 2002, the Association of Occupational Environmental Clinics took on this endeavor and was able to find funding both from NIOSH and the National Center for Environmental Health. And an expert panel was formed that met in Washington in 2003, and you see the members of that panel. Subsequently, this panel got together and issued an initial management guideline in 2006, which is still accessible online, and you have this resource. And that led to the publication of an article in Environmental Health Perspectives, and Dr. Kosnet was the lead article on that article, lead author on that article, and he'll be speaking about some of the findings from that article as part of our background for our discussion today. In California, the California adult blood lead prevention program began to work on a set of updated guidelines for adults and issued a draft which the Western Occupational Environmental Medicine Association was invited to review, and we gave input on those guidelines, and you see the panel members there, and I chaired that group. And this last April, the California Department of Public Health issued these guidelines. They are available to you at the URL locator at the bottom, and we're going to be discussing the application of those guidelines in this webinar. So what I'd like to do now is turn things over to Mike Kosnet and just briefly explain to the participants that Mike is going to be speaking about lead toxicity and the guidelines, and then we're going to have 3 case studies that Dr. Harrison, Dr. Meister, and myself will be walking through with you. And following that, we will do some pre-programmed questions and answers, and then we will turn to your questions. So please be entering your questions on the Q&A header of your web browser as we go along. So Mike, take it away.
Thank you, Jim. I'm going to address this morning, over the next approximately 30 minutes, some of the key medical concerns that have emerged in the recent years, predominantly over the past decade, about the adverse effects of low levels of lead exposure and how these particular health concerns have based desire to reduce acceptable or permissible levels of lead in the workplace. One of the key things that I wanted to start with, though, at the onset is to just review a few key points about blood lead concentration, because a lot of what I'm going to discuss refers to various blood measurements in whole blood. And it's good to put these in perspective. At the time that the OSHA lead standard was under development and initially introduced, the removal level for adults was approximately 50 micrograms per deciliter. It was actually a single blood lead concentration greater than 60, or the average of 3 measurements being over 50, that was set as a level that would mandate medical removal protection. Once an individual was removed from work for that elevated level, they were allowed to return to work once the blood lead concentration had fallen below 40 micrograms per deciliter. At the time that those standards were initiated, the U.S. population blood lead concentration expressed as a geometric mean was 12.8 micrograms per deciliter. As most of you are aware, blood lead concentrations in the general population have fallen substantially since then, largely as a result of the phase-out of lead and gasoline, but also because of reductions of lead in canned food and phase-outs of lead in paint. And for most of the past decade, the U.S. general population blood lead expressed as a geometric mean has been just under 1.5 micrograms per deciliter. The health effects of lead at low dose that have warranted our concern for more stringent control of lead level in the workplace really focus on 2 major areas. The chronic effects of cumulative dose those are really what I'm going to talk most about today. And in that regard, there are three major endpoints of concern. One has been the association between lead and hypertension. The second has been the association of lead on decrements in renal function. And the third has been the effects of cumulative low levels of lead exposure on cognitive dysfunction. There has also been data that indicates that adverse effects of lead may exist on reproductive outcome, particularly in females. And we're going to discuss that and cover that today, but we're going to talk more about that in one of the case studies than in the remarks that I'm making right now. So let's turn to some of the data that looks at the relationship between lead and hypertension. The data that has established this relationship really emerges from multiple lines of evidence. There have been a number of in vitro and in vivo studies that have been conducted in animal models and in tissue preparation that indicate that lead can affect vascular tone. Much of the evidence for this suggests that lead interacts with levels of calcium inside cells. And as you know, calcium is a mediator of vascular smooth muscle constriction. And it's believed that one of the key ways that lead may act to increase vascular tone is by interactions with calcium. There's also been evidence from multitude of animal studies that exposure to lead is associated with high blood pressure or elevations in blood pressure. And then there are also human epidemiological studies. And I'm going to talk a little bit about the latter too. The animal data exists in multiple species. And for purposes of today's talk, I just want to show you one particular study, which is small, but it was very well conducted. And it was performed over 20 years ago. This was a study by Dr. Fine and his colleagues in which they took 6 3-month-old female dogs and their matched litter mates, and then they fed them lead acetate or placebo at a dose of 1 milligram per kilogram per day for 5 months. And they were able to measure the blood pressure in these animals by Doppler in the foreleg without traumatizing the animals of any need for anesthesia. The blood lead predictably rose over this period of dosing to a level of 35.8 in the dosed animals versus 9.2 micrograms per deciliter in animals exposed to placebo. And if you also note on the bottom line of this slide that the blood pressure at 20 weeks in the animals who received lead was 120 millimeters of mercury, systolic blood pressure, versus 108 in those placebo animals. And this slide that we're seeing here basically shows you the significant differences between the lead-exposed group and the control group. Now you notice from about 0 to 30 weeks, even the control group increases their systolic blood pressure, and that's a natural function of the aging of puppies, of dogs. But there's even after that initial rise in both groups occurs, there's a persistent elevation in blood pressure in the animals who were exposed to lead compared to the controls. And these type of studies have been conducted in other species, including mice and rats and rabbits, and this is a consistent observation. Now, we can't do this kind of experiment deliberately in exposing humans to lead in a controlled panel, although they're exposed a lot in the environment. And there have been, of course, studies that have been done to humans who have been exposed to lead. And I'd like to discuss a little bit of that epidemiology. One of the key studies that illustrated the association between blood lead exposure or blood elevations in blood lead and blood pressure was the National Health and Nutrition Evaluation Survey. NHANES II, which was conducted over a period of approximately 4 years between 1976 and 1980, was a representative cross-sectional survey of the United States population. Approximately 20,000 individuals underwent detailed examination, and of those, somewhat less than half had blood lead measurements obtained. Now, the National Health and Nutrition Evaluation Survey is designed to be a statistical sampling of the non-institutionalized American population, and it's not designed with lead specifically in mind. It studies a number of different health endpoints and the relationship of various dietary and other factors, environmental factors on human health. Lead was just one of them. These people weren't selected, particularly because they had any particular lead exposure. In fact, their lead exposure was deemed to be just representative of the general population. And as you note, the mean blood lead concentration in the general population at this period of time was 13.1 micrograms per deciliter. And again, this was done, as I mentioned, in the late 1970s, just at the time when non-leaded gasoline was being introduced and being predominantly starting to be used in new vehicles. What it was found in this study was that blood lead was significantly associated with both systolic and diastolic blood pressure after controlling for age, body mass index, a number of demographic, and a number, exhaustive number, of nutritional factors. Let me show you the next slide, which was from a study taken from a subset of this NHANES finding, published by James Perkle at the CDC. This shows on the x-axis the adjusted blood lead levels after adjusting for covariance, and on the y-axis, the diastolic blood pressure. Now, this was taken from white males between the ages of 40 to 69. And each of the points, the data points that you see here, is a collapse or represents the closest 24 or 25 data points. So there are approximately a little over 600 actual data points that went into this regression line. But for purposes of clarity, only 25 data points roughly are shown. But what you see here is that going from a blood lead concentration of about 6 up to just about 38, there's about a 10-point increase in diastolic blood pressure after controlling for all other factors known to be associated with blood pressure. And this study raised considerable concern because this was, again, in the general United States population. And number two, what we can see here is that across blood lead levels that were widely tolerated in the workplace, there's an increase in diastolic blood pressure, which, when you consider that diastolic blood pressure is a major risk factor for cardiovascular mortality, such as fatal myocardial infarctions and strokes, suggested that this was a significant component of cardiovascular risk. Additional studies have also been conducted beyond just that NHANES study. And what we show here are basically some graphical representation of the findings from 2 meta-analyses that have been published of multiple studies conducted in both environmental and occupational settings. And I just want you to see here the key illustration of the fact that if you look at the association between blood pressure and blood lead in these slides, in these studies, you notice that almost all the studies are going in the same direction. Yes, they vary somewhat in magnitude, but they're almost all showing that blood lead is positively associated with an increase in blood pressure. The same thing you can see in this slide over here on the right, in which the association of a 5-point change in blood pressure is associated with basically a 1 or 1.25 millimeter change in systolic blood pressure. Now, you may think that in any one individual, a 1 point or 1.25 millimeter increase in systolic blood pressure does not necessarily have clinical significance. The significance of this is based on a population impact, because while this is the population mean effect across the general population, some people are probably more sensitive to the impact of lead on their blood pressure than others, just as some people are more sensitive to the impact of, say, sodium on their blood pressure than others. And in fact, to get a general population increase of 1 millimeter of mercury, that means that some individuals who are particularly sensitive to lead, have a much higher impact on their blood pressure as a consequence of their lead exposure. But the key finding is, across multiple studies in multiple countries and in multiple ethnic and age populations, there seems to be a relatively coherent effect. Now, those studies measured lead in blood, and one of the things that has occurred also in the past 10 to 15 years has been the use of a different biomarker, that being measurement of lead in bone. Lead in bone has certain advantages as a biomarker over lead in blood, because greater than 90% of the body lead burden is found in the skeleton, and it remains there with a half-life of years to decades. As a consequence, measurements of lead in bone reflect long-term cumulative lead exposure. And this is a picture taken from the laboratory at the Mount Sinai School of Medicine, in which non-invasive K-X-ray fluorescence is being used to measure the concentration of the lead in the tibia of an individual. And studies have shown that this single measurement, which can be conducted over 30 minutes, correlates well with an individual's long-term history of lead exposure. One of the key studies that emerged from the use of this biomarker of lead in bone was published in the Journal of the American Medical Association by Dr. Howard Hu and his colleagues in 1996. This study that was published by Dr. Hu was drawn from an ongoing study of the effects of aging on healthy individuals called the Normative Aging Study, which was an ongoing large prospective study of the health of individuals who entered the study at approximately middle age and were followed forward every few years, and their health was carefully monitored. Well, as a part of this cohort, Dr. Hu decided to compare what factors might be different between hypertensive and non-hypertensive individuals. So he studied 146 hypertensive men and 444 controls. And he conducted, in addition to looking at other covariates, he measured lead in blood and bone. And in the final logistical model that this study yielded, there were 3 significant risk factors for being hypertensive. One was the body mass index. The second was whether an individual had a family history of hypertension. And the third was their tibia bone lead concentration. And it's important to emphasize that these are just general population members from the Boston, basically recruited from the Boston area as part of this large ongoing study. These individuals did not have any particular significantly elevated occupational lead exposure per se. And in fact, the general lead exposure of these individuals across their lifespan was probably in the range of approximately 10 to 25 micrograms per deciliter. Going from the lowest quintile of bone lead to the highest quintile of bone lead, the odds of being hypertensive increased by 50%. Now, one might think because hypertension is a significant risk factor for cardiovascular disease, particularly ischemic heart disease, that general population studies looking at risk or morbidity and mortality for cardiovascular disease should show an influence of blood lead. And in fact, in recent years, this in fact has been detected. One study that was published in Environmental Health Perspectives in 2006 looked at the relationship between blood lead concentration measured in the National Health and Nutrition Examination Survey Phase 3, which was generally between the years of 1988 to the early 1990s. And at that time, they measured the blood lead concentration in just under 10,000 individuals who were 40 years of age or greater. And they followed these people longitudinally over the next 12 years to see who died of cardiovascular disease. And using those with a blood lead less than 5 micrograms per deciliter as the reference group, you can see that there was a 20% increase in blood lead in cardiovascular mortality, going to a blood lead concentration of 5 to 9. And when you got to the group that had a blood lead concentration greater than 10, there was more than a 50% increase in cardiovascular mortality, the relative risk being significant at 1.55, with a highly significant test for trend. A similar analysis conducted by Menke and his colleagues on this data set found similar findings. They analyzed the data in a somewhat different way and looked not just at cardiovascular mortality, but specific endpoints within cardiovascular mortality. And here they performed Cox proportional hazard ratios for mortality that were adjusted for multiple other factors, including age, ethnicity, diabetes, body mass index, smoking, and, well, just a number of other factors. Again, this is the general population sample. And you can see that taking individuals in the highest tercile of blood lead concentration, comparing them to those in the lowest tercile of blood lead concentration, there was a 1.89 increased risk of having a myocardial infarction and a 2.5-fold increased risk of having stroke. And again, this is a general population sample. These are individuals who, for the most part, had blood lead concentrations less than 10 at the time of the measurements. And these are significant risk factors for morbidity and mortality in the United States today. Another study that just recently got published in Circulation, and this appeared in print 3 months ago, followed up on the normative aging study, which I referred to earlier. And here they looked at how bone lead measurements predicted death over approximately a 9-year period of follow-up in individuals who were in the Cohort study I mentioned earlier, the normative aging study, in which a relationship between lead and blood pressure was shown. And what you see here is that, looking at the middle column of this table, which shows the hazard ratios according to tercile of patella lead, that if you go to the far right, those in the highest tercile had a 2.45 increased risk of dying from cardiovascular disease compared to those in the lowest tercile. If you excluded, and this is in the bottom line, individuals who had a history of heart disease or stroke at the time of their entry into the study. In other words, individuals who were perfectly healthy at the time that they were first studied about 9 years earlier, there was more than a 5-fold increase risk of having a death from a cardiovascular endpoint. So what they're showing here is that in the earlier study conducted in the 1990s, bone lead concentration was shown to be associated with hypertension. What they're showing as they follow these individuals later is that, not surprisingly, a risk factor that increases high blood pressure also is associated with an increased risk of death from cardiovascular disease. As I mentioned earlier, there's also been studies associating levels of lead in blood that are encountered by people in the general population, but also particularly in the workplace, with decrements in renal function. One such study, which was published actually in the early 1990s by Dr. Stason and his colleagues, looked at a random population sample of approximately 2,000 men and women who were living in Europe, who had blood lead concentrations that ranged from very low to up to about 72.5 micrograms per deciliter, but most of them had blood lead concentrations in the neighborhood of around 10. And there was a significant correlation between their age-adjusted creatinine clearance and their blood lead level. And you can see that shown on the slide here, in which the y-axis is the creatinine clearance, men being at the top, women being below, and blood lead concentration. This is shown, by the way, in micrograms per liter, not micrograms per deciliter, because the study was published based on a European population, so they didn't use micrograms per deciliter. But what you can see is that there's a significant relationship, and that relationship persisted even after excluding individuals with occupational lead exposure, or those in the highest tercile of blood lead. There have also been several studies that have looked at an association between cumulative lead exposure and cognitive function. One study that was recently published by Dr. Khalil and his colleagues was interesting in that it reappraised individuals who had originally been studied in 1982. So they had initial blood lead measurements and neurocognitive function studies done on them in 1982, and then they went back and tried to locate as many people as they could and study them again in 2004. In this latter study, in this latter time point, also adding measurements of lead in bone. You can see that the blood lead concentration in 1982 among the workers was 40 micrograms per deciliter, and by 2004, it had fallen to about 12 micrograms per deciliter. And in fact, most of these individuals were no longer being exposed to lead at that time. The controls had a blood lead concentration of 7.2 in 2004, and it had fallen to 3 I had 7.2 in 1982, and it had fallen to 3 in 2004. And the bone lead measurements of the exposed workers was almost 5-fold higher than those of the unexposed subjects, which is not surprising because these individuals had a long history of working in the lead industry. What you see here is that the bone lead concentration was a significant predictor of the change in cognitive function of these individuals over time. In individuals who were exposed to lead, their bone lead concentration significantly predicted a worsening of their performance, both on their total cognitive score and also on some subsets of cognitive function, including spatial functioning and executive functioning. In the placebo group, or excuse me, in the non-exposed group, these are individuals who were controls, who were not lead workers, that significant relationship of bone lead with a decline in cognitive function was not detected. Interestingly enough, it was this bone lead measurement, which is a reflection of an individual's cumulative lead exposure, that predicted the decline in cognitive function. It was not found with just looking at their blood lead alone. The lead-exposed workers experienced a 17% greater loss in total cognitive score compared with the non-exposed workers, or the non-exposed control. Another study, which looked at the relationship between cumulative lead exposure and cognitive function, was the Baltimore Memory Study. This was a study of 991 randomly selected sociodemographically diverse individuals who were recruited from various communities in the Baltimore area. They were between 50 to 70 years of age. Their mean blood lead concentration was relatively, as might be expected for the general population, low, 3.5 plus or minus 2.2 micrograms per deciliter. What was interesting is that their bone lead concentration, these are just general members of the population, within this cohort, their bone lead concentration was a significant predictor of the decrements in visual-constructive skills on neuropsychiatric testing. In fact, a 13 part per million increase in bone lead had an equivalent impact of 4.8 years of age. Now, what's significant to realize in terms of the impact of this on health and functioning is that when we talk about people who are approaching their senior years, 4.8 years of additional a 4.8 year acceleration in the effect of aging on cognitive function is significant. I mean, if you take a person who is 75 and perhaps compare them to someone who is 80 in terms of the risk of decline of cognitive function, it's substantial. So if you have a risk factor such as lead, which causes or is associated with these magnitudes of impact on cognitive function in an aging group, it suggests that this has a significant, or has the potential to have a significant public health impact. The normative aging study, again, has proven to be a very rich source of data on the impacts of lead. And in this study, they looked at the impact of bone lead on neuropsychiatric testing in approximately 1,000 individuals who had a median blood lead of only 5 micrograms per deciliter at the time of study. But what they showed here, and as you can see in this slide, the bone lead measurement is shown on the x-axis, and the response latency on pattern recognition is shown on the y-axis. The longer the latency in response, the worse the performance. And what you can see is that there is a significant association as bone lead goes up in individuals' cognitive function in terms of this particular test on visual spatial performance decline. An interesting follow-up to this particular study was the fact that they looked at a subset of individuals in this study who were 31 older men at 77 years of age, none of whom had Alzheimer's disease or obvious dementia. None of them were demented, but they underwent both X-ray fluorescence bone lead measurements and a new technique, non-invasive proton magnetic resonance, to scan specific brain tissue metabolites in the hippocampus. They can look at using this proton magnetic resonance, they can actually look at things like myeloinositol and other markers of various tissue types in the brain. The next slide shows that in these individuals, there was a significant relationship between their bone lead measurement and concentration of myeloinositol in their hippocampus. And what's interesting about myeloinositol is it's a component of astrocytes. And these are believed to be a biomarker of glial proliferation and plaque formation in the brain that is present in the preclinical stages of Alzheimer's disease. Studies like this have raised concern that cumulative exposure to lead earlier in life or over the course of a lifetime can be a risk factor for the development of Alzheimer's disease. And again, this was taken from individuals who were involved in the normative aging study who probably lived most of their adult lives with blood lead concentrations between 10 to 25 micrograms per deciliter. Bearing this and other data in mind, a group of colleagues, of whom I was one, wrote a paper in Environmental Health Perspectives in March of 2007, in which we made recommendations for the medical management of adult lead exposure. And this table basically summarizes some of our key recommendations. We believe that for individuals who have blood lead between 5 to 9, there's an indication to discuss health risks and to try to suggest ways in which lead exposure can be reduced. We think it's particularly important to reduce lead exposure for women who may become pregnant. And we'll talk a little bit more about pregnancy in one of the case studies coming up. Between a blood concentration of 10 to 19, efforts should be made to not only decrease lead exposure, but to increase biological monitoring, and to consider removal from exposure to avoid long-term risks if the patient, if exposure controls do not allow the blood lead to fall less than 10, or if the individual has another medical condition present that increases the risk of continued exposure. For blood lead levels between 20 to 29, we believe that they should be removed from exposure if a repeat blood lead measurement conducted in 4 weeks remains greater than 20 micrograms per deciliter. For individuals who have a single blood lead measurement between 30 to 39 or higher, they should be removed from lead exposure. For blood lead concentrations between 40 to 79, they should not only be removed from lead exposure, but they should be referred for prompt medical evaluation. Chelation should be considered for those with blood lead concentrations greater than 50 who have significant signs or symptoms. For those who fall into a blood lead concentration greater than 80, which will certainly be quite rare, they should not only be removed from lead exposure, but referred for immediate or urgent medical evaluation and probable chelation treatment. Just to comment very briefly, chelating agents decrease lead concentration in the blood and in certain tissues and greatly accelerate urinary lead excretion. But there are no randomized placebo-controlled trials of chelation that indicate that it improves the therapeutic outcome of patients. Bearing that lack of data in mind, it's still generally our opinion that blood lead concentrations greater than 100 almost always warrant chelation, that chelation can be considered for those with blood lead levels between 80 to 99 who may or may not have symptoms, and for individuals who have blood lead concentrations greater than 50 if they are in fact symptomatic in a manner that is consistent with the effects of lead. Chelation is not recommended for asymptomatic individuals with low blood lead concentration. It's important to bear in mind, too, that chelation predominantly will reduce lead in the soft tissues, and the rate of decline of lead in the blood will be greater than the rate of decline of lead in the central nervous system. As a consequence, individuals may not recover from the adverse CNS effects of severe lead poisoning in a time frame consistent with a more rapid decline in their blood lead concentration. And older workers in particular, those with long-term high dose lead exposure, may have a diminished capacity to resume pre-morbid function and be returned to work, even if their blood lead concentration falls dramatically with chelation. This is a quick slide in passing I wanted to show in which animals who were exposed to lead underwent chelation, and what you can see is that there's a big decline in the blood lead concentration over the period of chelation, but there's relatively little decline in brain lead concentrations during the period of chelation. This slide, which I won't go through in detail in the interest of time, indicates recommended medical surveillance. The recommended medical surveillance that we have put forward in this table indicates basically that individuals with blood leads less than 10 should generally undergo blood lead monitoring every 6 months. Individuals between 10 to 19 every 3 months. And once an individual has a blood lead concentration greater than 20, which may be a trigger for medical removal if it persists when remeasured, should undergo monthly blood lead measurement and be considered for a return to work after 2 blood lead levels are less than 15, taken a month apart. Another key component of our surveillance recommendation is that they should apply to all potential lead-exposed workers, not just those who have a workplace where there's a documented elevation in air lead levels. The current OSHA lead standards basically trigger the need to enter into various aspects of the medical surveillance program if air measurements of blood lead are above, air measurements of lead are above a certain action level. It was our belief that because of the potential for hand-to-mouth exposure and other routes of exposure exclusive of just measuring lead in the air, that there is a need for medical surveillance that is not just restricted to workplaces in which air monitoring has been documented to be elevated. Also, because we are now recommending that individuals not have long-term exposure to lead in the workplace in excess of certainly 20 micrograms per deciliter, it's unnecessary to include certain components of medical surveillance that is now suggested in the OSHA lead standards, such as CBC or urinalysis, because we would expect that in individuals who have blood lead levels maintained less than 20, there would be no yield in measuring or looking for impacts on CBC or urinalysis. So this, in effect, can save some of the costs of medical surveillance by eliminating these unnecessary tests once blood levels are kept at a lower level. The impact of these recommendations in, or the logistical capacity for these recommendations to be adopted are going to be somewhat challenging because and they may need to be phased in over a period of time, because even if we were to lower the permissible levels of lead in the workplace today, people who have worked in the lead industry for a number of years will have built up lead in their bones to the point that their past lead exposure will be a greater predictor of their blood lead than necessarily their current air exposure. And this was shown in a study that was performed by Hodgkins and colleagues and published in the Journal of Occupational Medicine in 1991. They looked at predictors of blood lead levels in battery workers. These workers had basically had a seniority of work on average about 20 years. And in the past, they had much higher lead levels than they had at the time that their blood lead and their blood lead was measured in 1985 when the data for this was taken. And what you can see is that these various predictors of their blood lead level include their seniority or how long they had been working, but it did not include the measurement of lead in the air of the factory in 1985. It suggested that their blood lead was more influenced by their past lead exposure than their current exposure. A study that was, or analysis that was conducted by John Freund and published in 1995 did suggest, however, using a toxicokinetic simulation, that if the PEL or if air lead measurements were kept at 25 micrograms per cubic meter, which are approximately half of the current PEL of 50 micrograms per cubic meter, most of the workforce, approximately 90% of it, could maintain blood lead concentration less than 20. And this assumed that the population or baseline average blood lead measurement of individuals, independent of their getting workplace exposure, was 6 micrograms per deciliter. Since today, the background lead concentration is approximately 1.5, it suggests that perhaps even more than 90% of the population could maintain a blood lead concentration less than 20, even with an air concentration that was, or a PEL that was reduced to 25 micrograms per cubic meter. And as a final point, I want to note that the current OSHA standards, even though they have medical removal provisions that, as mentioned earlier, were set at, say, 50, based on blood lead measurements, do allow physicians the discretion to remove individuals at lower lead concentrations. It says, in this quote, recommendations may be more stringent than the specific provisions of the standard. The examining physician, therefore, is given broad flexibility to tailor special protective measurements to the needs of individual employees. In summary of the points we've gone over, the 1977 OSHA lead standards are insufficiently protective and are outdated. Low to moderate levels of lead exposure are associated with a risk of hypertension, decrements in renal function, cognitive dysfunction, and adverse reproductive outcomes. The goal is to keep blood lead concentrations less than 10, single level over 30 or 2 consecutive blood leads over 20 merit medical removal, and chelation should be reserved for individuals with very high blood lead concentrations. Thanks very much.
Mike, thanks very much for a great overview. This is Jim Seward again. I just wanted to remind listeners that the Environmental Health Perspectives article that you were referring to is a public access article. It was from March of 2007. And similarly, the guideline that the California Blood Lead Prevention Program has developed is available to anyone online, and you could just do a search on that. And we gave you the URL in the earlier slide. We're now going to go through 3 cases, and Bob Harrison has the first case.
Thank you very much. Nice to meet everybody online here. I'm going to quickly present a case that illustrates, I think, one of the key points that Dr. Kosnet made, particularly highlighting the issue of underlying renal and hypertensive disease. As you recall, one of the new recommendations in the Environmental Health Perspectives paper and the Department of Health guidelines is to consider medical removal above 20 if there are underlying or coincident chronic diseases, including hypertension, diabetes, cardiovascular disease. Here's an example of a case that I treated at UC San Francisco and, in fact, continue to treat. He was a 46-year-old man who worked as a furniture stripper for 7 years. This was a little bit of an unusual exposure in my experience. He worked in a furniture stripping factory where old furniture was cleaned up with a highly toxic solvent, methylene chloride, but then any residual paint was power and hand sanded off. The furniture dated from the 1940s and 1950s, contained lead. He had done this for 7 years. It was a typical small shop with poor housekeeping, no injury and illness prevention plan or workplace health and safety program. There was no routine medical monitoring, including blood lead testing in this plant. He had last worked in June of 2006 and had seen multiple healthcare providers as primary care physician, neurologist, endocrinologist, and in January of 2008, an alert clinician took an occupational history some 18 months after he was initially off of work and examined. At that time, his blood level was 25 micrograms per deciliter. Recognizing that this was, although technically within the normal range of the laboratory report, was elevated above the background, the primary care provider repeated the blood lead 4 months later, and you can see it was 16.3 at that time. And then several months later referred the patient to see me. He had a 2-year history of abdominal pain and burning, numbness and tingling, paresthesias in his lower extremities. His past medical history was significant for diabetes for over 15 years. And you can see his hemoglobin A1C was 12.2 at the time of examination, normal being less than 6. Therefore, he had very poorly controlled diabetes, had very poor access to health care, and was poorly compliant with his medications. His renal function was normal with a creatinine of 1 and a BUN of 10. He had been placed on multiple medications for neuropathic pain. His physical examination was normal, although his nerve conduction studies, which I don't have to show you here, did show a mixed sensory motor polyneuropathy, highly consistent with long-standing diabetes, with perhaps some contribution from his chronic lead exposure. You'll recall that he had a blood lead of 16 in April of 2008. When that was repeated in the fall of 2008 and over the last year, his blood lead did fall rather quickly and is now less than 5 micrograms per deciliter. He was removed from exposure and, in fact, is continued to be off of work and eventually filed and received workers' compensation disability. So this case illustrates, in the, if you will, the pre-2007 Environmental Health Perspectives recommendation, a case that probably would continue to work with a blood lead of 25, but given the data that Dr. Kosnet so eloquently presented, should be promptly removed from exposure or assigned an alternative job away from lead with repeat blood lead testing until blood lead levels drop below 10, as happened in this particular case. This situation, also illustrates the importance, obviously, of taking a good occupational health history. He had worked around lead for a period of 7 years, and I think were it not for an alert primary care provider, would probably be still working exposed to lead. Fortunately, removal resulted in prompt decrease in his blood lead level. I want to show you just one other slide, which illustrates here on the y-axis predicted changes in serum creatinine over a 10-year period, and on the y-axis, tibial blood lead levels on the left and blood lead levels on the right. And you can see that the white bar, the non-diabetic patients, and the blue bar, the diabetic patients, the black bar, the hypertensive patients, the predicted changes in creatinine are much less dramatic with underlying diabetes and hypertension when there's elevated tibia and blood lead levels, indicating that long-term accumulation of blood lead is associated with an increased risk of declining renal function, particularly among individuals who have underlying diabetes or hypertension. Thank you. I'll pass this now on to Dr. Meister for his case.
And Ray, are you able to advance the slides now?
Yeah, I think I am.
Good.
Thank you. Yes, hello everyone. The case I'm going to present is kind of a classic case of someone who's been exposed to high lead levels for many years, and we unfortunately periodically see these sad cases, and I'm going to move through this fairly briskly so that we can hopefully also leave some time for questions at the end. So my case is a 61-year-old male who was an automotive radiator repair worker for 39 years. And during that time, he rarely used any personal protective equipment or had any engineering controls available to him. He presented with a 6-month history of increasing fatigue, loss of muscle strength, loss of endurance, foot pain, decreased concentration, poor memory, and a tremor. He also reported longer-term troubles with libido, his mood reportedly being short-tempered, and high blood pressure. He saw a new physician, which was a good thing for him, because this person obtained his first ever blood lead level. This result came back at 67 micrograms per deciliter. Based on this initial level, the initial management included repeating the blood lead level, and I'd like to put in a plug here for doing a very quick repeat blood lead level whenever you get an elevated result like this, as we occasionally do see high levels which end up being some sort of laboratory error or decimal place in the wrong position. So it's always important to repeat a blood lead level. But in this case, it was, in fact, an elevated level. So at this time, he had a complete physical exam. Additional laboratories were done. He was removed from lead exposure and placed on medical removal protection as per the lead standards. And there was some consideration to providing him modified duties as medically appropriate. Further evaluation and labs, 9 months after his initial blood lead level, the patient essentially had unchanged symptoms. These symptoms continued. His blood lead level had fallen to about half of what it was before, down to 34.5. And he, at this time, had a very complete evaluation with an occupational medicine specialist, actually Dr. Kosnet in this case, and he obtained a KXRF measurement of his bone lead concentrations. This next slide shows the results from his studies. You'll see that his tibial blood lead level was measured at about 80 micrograms per gram, and a common value for someone who had just environmental exposures in this age group would be 20 to 30 micrograms per gram. So you can see that this fellow is 3 to 4 times elevated in that measurement. And the calcaneus and patella measurements were also elevated anywhere from 4 to 6-fold expected levels for his age. These levels, of course, are consistent with a chronic high-dose lead exposure history that had occurred for many years. And if you go back and look at some of Dr. Kosnet's earlier slides, particularly 29 and slides 31 through 36, you'll see that this person's blood lead or bone lead levels squarely put him in the range to suffer the effects that those slides noted. So further management for this gentleman included continued temporary total disability secondary to his lead exposure with removal from any work associated with lead. And although modified duties were considered, he ended up being placed on total temporary disability at this time due to his ongoing symptoms. Jumping ahead to 30 months after his initial presentation, so 2.5 years into this, his blood level was still in the 30s, and at this time it was up to 40. At this point, another evaluation was done. It was determined that he had chronic lead poisoning through California workers' comp. He was made a qualified injured worker and provided with a future medical benefit. And his lead levels were recommended to be rechecked every 6 to 12 months. So I asked the question here, will his level remain above 35 years after initial evaluation? And unfortunately, the answer is yes. On the y-axis here is his blood lead levels in micrograms per deciliter, and then along the x-axis is the months since his first blood lead level. And you can see going out to almost 6 years here, his levels are still basically fluctuating around in the 30s. And again, this is a pattern that we've seen repeated several times with workers with this sort of exposure history. So for me, some of the important points that this case raises are to always have that awareness, as the primary care physician did in this case, to think about workplace exposures, and in this case, lead exposure, and to order the blood lead level test if there seems to be any indication at all to do that. Other questions it raises is, what sort of modified duty can be provided to a worker like this in a situation like this, and can someone who has been chronically exposed remain in a lead-using job, especially now with what we know about the effects at low levels and chronic exposures. And then I won't spend a lot of time on this slide, but I did want to mention the concern for take-home lead exposures where lead is inadvertently brought home on the clothing or in the vehicle of a worker, and then people in the home are poisoned, typically young children. And I'm always shocked to see how long it takes a lead-poisoned child to have their blood lead level come down, even once the source of the lead exposure has been identified. And this slide points out that it takes many, many months for a child with high lead level for that lead level to come down under 10. And in one study that looked at these kids, just one example I'll give you is for children with lead levels of 25 to 29 micrograms per deciliter, the average time that it took for their blood lead levels to decline to less than 10 micrograms per deciliter was 2 years. So again, if these children get poisoned, it's unfortunately being committed to many, many months of elevated blood lead levels. Great. And with that, I'll hand it over to Jim Seward.
Okay. I have a case that relates to reproductive disorders in women related to lead. This is a hypothetical case, and it's a 24-year-old woman, a female employee in a home renovation company who is frequently required to burn and scrape old paint off of woodwork. And I'd just like to point out that in recent ABLES, the Adult Blood Lead Epidemiologic and Surveillance Program surveys, 95% of elevations of adult blood lead, which I think was defined as more than 25, were occupationally related, and that painters were one of the occupations that is most heavily affected. And some of the other occupations would have been people working in battery production, mining and refining of lead or zinc. So that's key occupational data to keep in mind. In any event, she's attempting to conceive, and she comes to you for advice, and you find a blood lead level of 11 micrograms per deciliter and a positive urine pregnancy test. I wanted to refer back to some of the language in the guidelines related to medical surveillance from OSHA. This is a slightly different section than than the one that Michael referred to earlier. And I'm not going to read the whole thing through, but it does say that based on history, physical examination, and laboratory studies, the physician may recommend special protective measures or medical removal for an employee who is pregnant or is planning to conceive a child when, in the physician's judgment, continued exposure to lead at the current job would pose a significant risk. So there's a regulatory basis for physicians to use their best judgment in assessing a situation such as the one I just described. And there's good evidence now that there are significant reproductive risks at quite low levels, lower than for some of the other problems that we have been discussing. In a prospective study that measured blood lead levels in pregnant women, there was found that there is a substantially elevated risk of spontaneous abortion in women who have blood lead levels in the range of 5 to 9. And progressive on through higher levels, 10 through 14 and greater than 15. At greater than 15, the odds ratio was 12.2, and the study also showed a positive test for trend. So that is a significant, spontaneous abortion is a significant concern. There's also a real concern for the effects on the fetus related to the cognitive development and postnatal IQ. This is another Mexico City study. There's a prospective study, and the average third trimester lead was only 7.8. But with every doubling of the maternal blood lead level during the third trimester, there was an associated decrease in the child's IQ of 2.7 points at age 6 to 10. And this is a study of 150 people. There are other lead effects on maternal-child health. There's evidence for decreased birth weight. A study looking at birth weight showed a decrease of 150 grams for infants born in the top quartile of maternal blood lead compared to the bottom quartile. There's also evidence for decreased head circumference. Once again, a doubling of blood lead in this study showed a decrease of a third of a centimeter in the exposed group compared to the controls at 6 months. The women also experience an increased risk of maternal hypertension during pregnancy and increased cord lead, heel lead on X-ray fluorescence, and blood lead all correlate with maternal blood pressure. So the recommendations that that Michael was discussing earlier indicate that we would recommend removal of a woman from lead exposure if her blood lead level were greater than 10. And in fact, in this case, it's 11. I would say that as a practice in management, if I could repeat that blood lead level without a significant delay, I might do that. But then I would recommend that this individual have some alternative duty where she wasn't exposed to lead, or if necessary, remove her from the workplace altogether. A couple of other thoughts about this case. The first would be that it would be a good idea to recommend that she take additional calcium because that might prevent some of the reuptake of the lead, whatever lead's in her diet, as well as reabsorption from bone, and reduce the amount that's available to the fetus. And the second thing to consider is that lead is also secreted in the breast milk, and so concerns for ongoing exposure during lactation and breastfeeding would be something that the physicians need to follow up on in this case. Had her blood lead been in the 5 to 9 range, the recommendation would have been to take measures to reduce her exposure if feasible and to monitor that. And I would say monitoring should be done pretty frequently. I would say in that situation probably monthly. So now we move on to our question and answer session, and we will just fairly quickly run through these questions, and you should be thinking about your answers, and then we'll go and move on to your questions. So question 1 is chronic occupational lead exposure has been associated with all of the following health conditions except A is hypertension, B would be pulmonary fibrosis, C is cognitive dysfunction, and 3 is four is detriments in renal function. And the correct answer here would be B, pulmonary fibrosis has not been associated with lead exposure. And Mike, are you able to do the second question?
Sure. The second question reads, all of the following regarding lead chelation are true except A, there are no randomized placebo-controlled clinical trials that demonstrate improved therapeutic outcomes. B, blood lead levels greater than 100 micrograms per deciliter almost always warrant chelation. C, during chelation, lead levels decline faster in the brain than in the blood. And D, chelation increases the urinary excretion of lead. The correct answer here is C. It's not the case that blood lead levels decline faster in the brain than in the blood. In fact, the inverse is true. We'll move on to the next question.
Okay, yeah, that's Bob, that's yours.
Regarding medical removal protection, or MRP, which of the following is incorrect? A, recommendations for MRP may be more stringent than the specific provisions of the standard. B, the examining physician is given broad flexibility to tailor special protective procedures to the needs of individual workers. C, MRP is only triggered once the worker has a blood lead level at or above 50 micrograms per deciliter. Or D, the examining physician may recommend special protective measures when considering the management of pregnant workers as well as male and female workers who are planning to raise children. The incorrect answer here is C. MRP can be triggered at the discretion of the physician. You'll recall Dr. Kosnet covered that point in the OSHA lead standard. Moving on to the next question.
Great, this is Ray Meister. That one was mine.
Oh, okay, let me adjust the questions here. There we go.
Great, thank you. Number 4 is a true-false question. An elevated blood lead level is always associated with elevated current exogenous lead exposures. And the answer here, of course, is false. As was illustrated by the case I presented, especially with high and chronic exposures, a person's blood lead level can remain very elevated even years after the removal from lead exposure.
Okay, our final challenge question here is the current health-based management recommendations for lead-exposed women who are or may become pregnant includes reducing lead exposure at which of the following blood lead level range thresholds? A would be less than 5 micrograms per deciliter, B would be 5 to 9, C 10 to 19, D 20 to 29, and E 30 to 39. And the answer here would be B, that we would look at reducing exposure at the 5 to 9 range and consider removal above that.
This is Michael Cosnet. I just wanted to add one other point regarding that last issue of removing from work with lead individuals who are pregnant. The Centers for Disease Control has an advisory committee on childhood lead poisoning prevention, and they have recently completed a guidance document on lead in pregnancy, which is now undergoing internal clearance review at the CDC, but is expected to be released this spring. And this document it's over 100 pages, and will have actually an extensive discussion of the various issues on dealing with lead exposure during pregnancy, both in individuals who are working or who are exposed through other means. But my expectation is, once this document is finally released, that you will see that there will be a formal CDC recommendation for removal from lead exposure on the job of any woman who is pregnant and has a blood lead concentration of greater than 10. And that for levels between 5 to 9, steps should be taken promptly and decisively to try to lower lead exposure. So keep your eyes open for that official CDC guidance document, which will be basically consistent with the recommendations you heard today. Well, we have an opportunity now also for individuals who are in our cyberspace audience to ask questions. We have one question that's been posed to the panel, and I will read it, and we can entertain some discussion. It says, do physicians involved in occupational medicine or in charge of following workers for lead screening also meet and provide preventive services to managers of the owners of industry? And why don't I open that up to any of the panelists? Ray, you've been involved in looking at a lot of lead industries in California. Is it common for occupational health physicians to also provide preventive consultation, or how actively are they involved with management?
Well, optimally, they are involved with management, and often we see that they are. As with many things in occupational medicine, a multidisciplinary approach usually works best. And where we see the most benefit, from these relationships is when the occupational medicine provider, is working both with management and also with the employees to keep everyone up to date and informed of exactly what's going on, and hopefully you have a cooperative environment where everyone is working together, with the best health and safety, decisions being made.
Okay. Thank you, Ray. We had another question that was posed. Are zinc protoporphyrin levels indicated in individuals who have been noted to have elevated blood lead levels? And I will give a stab at answering that. I should preface this by saying that the routine OSHA medical surveillance recommendations now, under the OSHA lead standard, call for not only monitoring blood lead, but also measuring zinc protoporphyrin. And as you know, zinc protoporphyrin, which reflects the adverse effect of lead on hematopoiesis, can be elevated in individuals who have elevated blood lead concentrations. And the zinc protoporphyrin elevation generally does not occur or begin to appear before individuals have blood lead concentrations that exceed approximately 30 micrograms per deciliter. And another thing about zinc protoporphyrin is that there's often a lag time of several weeks between the time that the blood lead level is first elevated and the zinc protoporphyrin level increases. My sense about the utility of zinc protoporphyrin in medical evaluation of lead workers is as follows. I don't recommend it routinely. However, if I find that a person has an elevated blood lead concentration, I will consider ordering soon thereafter a zinc protoporphyrin level because it may help me understand the time frame of the person's exposure. If an individual who has an elevated blood lead concentration, say 50 or 60, has a normal zinc protoporphyrin, I can be relatively confident that their exposure has occurred recently, within the past few weeks, and hasn't been a long-term ongoing issue. So I think that helping to understand the time frame of exposure is helpful. If an individual has an elevated blood lead level and an elevated zinc protoporphyrin level at the time, at a single point in time, that could be consistent with the fact that their lead exposure their elevation of lead exposure first occurred more than a few weeks ago. However, one needs to consider that there are other sources or other causes of elevated zinc protoporphyrin concentration, the most common being iron deficiency, but also certain hemoglobinopathy. And I believe we have one more question that is posed, and I will read it to the group. It says, I have a chronic lead exposure patient whose first blood lead concentration in 2005 was 71. He was removed, they instituted engineering controls, and his current blood lead level is 35. Can he be sent back to work in an area where the air monitoring is within the limits and restrict him from high lead areas? Jim or Bob, would you like to comment on that?
Actually, I'm going to turf it back to Ray or Jim. Ray, this is probably a pretty common case that you get in the blood lead registry.
Yeah, exactly. And one thing that I think is very important here is to have a very in-depth discussion between the healthcare provider and the worker to see, what the worker's desires are, and to carefully consider, all the options that are available, whether it's going through workers' comp and, qualified injured worker, that sort of thing, versus if this is a well-paying job and one that the person is highly trained for and desires to keep working at. All those sorts of things, need to be considered. The current OSHA standards, do give leeway for healthcare providers in consultation with the worker to make recommendations in these sorts of situations. And I think basically you have to weigh the medical, the medical side of things, the potential adverse medical outcomes versus the employment and the need for employment and the need for people to, have a good paying job and support themselves and any others who, may be relying on them. So to sum it up, these are difficult situations, and I think a lot of discussion needs to happen between the healthcare provider and the worker. And then if the worker should be returned to work, to closely monitor them.
I would.
Michael, I'm sorry, Michael. Go ahead. I was going to tell you to take a quick crack at one last question, which I think would be a good ending note.
Okay.
Someone submitted a question that reads, the scientific review is very revealing, and I doubt that anyone can argue with it. What I'm hoping to get out of this webinar is a practical understanding of how we as occupational physicians tiptoe through the delicate matter of educating the employers. Whoops, the question just disappeared. Educating the employers with whom we work as to the reasons why they should expand funding to lower levels in their employees below the current OSHA requirements. How do we tell them that legal compliance does not result in meeting their scientific and arguably moral obligation to their workers' health? Boy, this is a challenging question, but there's a couple points I would like to make. First, I think this is sort of the paradigm we often face in occupational medicine, and you know, we can do our best at communicating clearly our rationale, sitting down with employers and with employees, when there are strong economic incentives, we unfortunately sometimes may not be successful. In this case, though, I think we've been trying to point out that the standard does give us a legal basis for making these medical determinations. That may not prevent a employer who's not open-minded from going to seek other medical advice in the future, but I think we do have a regulatory basis for the positions that we have been putting forward in these guidelines today. I think it also emphasizes the importance of moving forward to strengthen the standard. We have begun an initiative like that in California to ask Cal-OSHA to review the existing Cal-OSHA standard. There is an ACOEM committee which is going to begin meeting to discuss a similar initiative with respect to federal OSHA, and maybe I'll leave it at that.
Well, I'd like to thank all of you for your attendance and thank our presenters for their valuable presentation. This does conclude today's program.